for your declaration. Now I am going to the next lecture. This will be given by renowned interventional cardiologist, Dr. Sanjog Kalra from Canada. He is an international committee member of SKY. He will talk about case planning for complex PCI, 5 steps to success. Now I am requesting Dr. Sanjog Kalra to give his lecture.
Thank you very, very much for your gracious invitation to speak, and again to the Bangladesh Society of Cardiovascular Intervention for the opportunity to be here today. I miss Bangladesh. I miss visiting in person. It's been my privilege to be there the last few times with all the dear friends that I've developed. So you're all in our hearts and prayers on this side of the world, knowing how difficult a time it is there for you. I have my hand raised because I just wanted to, just before we go on with my talk, I wanted to highlight a question that was asked in the chat box to Dr. Dagobati. The question was, what is the recommended contrast amount to complete a coronary angiogram?
So I would say, Sanjog, that's a very good question. I use the same principle for radiation and contrast. Alara principle, as low as reasonably achievable. So I actually used 11 cc contrast one time in a patient with CKD, and he still developed renal failure on top of that. And so he went on to dialysis. So there is no minute amount of contrast can cause still a damage. So, but whatever we have to do it. We need to make sure that they understand the risk, benefits, and alternatives, and we need to use contrast. Sometimes we have to do it. So zero contrast PCI is actually something that we are doing now. If somebody has done an angiogram and they come to us and with the CKD, we do not use any more contrast. We are actually not taking any pictures. We use IVUS and FFR to determine where exactly we need to stent, and just leave the patient without any contrast.
Indeed. So that's, I mean, there you have it, to Abida Tasneem Reza, who asked that very good question. The answer is as little as possible, but as much as is necessary. Remember that a bad angiogram is a complication because you have front-loaded all of the risk, but given your patient none of the benefit of the test that you're doing. Zero contrast PCI, one of the things that I think some people have seen is some of your colleagues in Bangladesh performing these procedures as well. They're not technically difficult. You just have to understand that you're seeing using a different way of seeing. You're not using contrast, you're using IVUS. So with that, I will move forward and share my screen. And thank you again for the opportunity to speak. This is an interesting talk for a fellows course. When I suggested the topic, I sort of wondered about it and said, was this a bad idea? But I guess when you think about complex PCI, really what it comes down to is doing the same things over and over and over again to make sure that whatever results we get are reproducible and consistent, right? As interventional cardiologists, we're pretty simple people, right? You want to open arteries, you want to fix valves, you want to make sure big holes that should be there should be closed. So that requires about the same approach every time you use it. And so my hope over the next few minutes is to take a case that you would consider pretty complicated and try to simplify it into a basic 5-step process, basic 5-step framework. And with that framework, maybe we can help make a simple case seem a lot easier than it is. So trying to tell you everything about complex and high risk planning and strategies in 12 minutes or less is a little bit like this, right? Trying to take a ton of knowledge and dumping it on your head with absolutely no way of you taking it away. So through this, I want to try to concentrate on that framework. So here it is. Number one, never take the wrong patient for the wrong case. Always take the right patient for the right case. So identify patients who need you, those who have a suitable reason to come to the cath lab, and those who need PCI performed. As Dr. Dagobati highlighted a few minutes ago, individuals should be maximized on medical therapy when they have stable ischemic heart disease, unless you're doing their cases to complete revascularization, or unless they have poor LV function, or unless they have an acute coronary syndrome where you have independent indications for revascularization. So when looking at a complex PCI patient, remember, are they a true surgical turn down? Are they a referral from other CHIP patients? Are they people that understand you and with whom you can develop a trusting relationship? Because ultimately, when you provide complex PCI, the bedrock of that is not what's in your hands, it's what's in your heart. It's making sure that you have a connection with your patient and your patient believes, looking into your eyes, that you are their advocate, that they are able to trust you to be their voice, and that you are only going to do the things that are going to do them benefit, because you're putting them on a table and putting them at risk. Remember that you owe them that.
Can
Make
you
sure
please
that
come closer to the device?
Sure. Can you hear me now?
Yes, because
little better?
sound is not clear.
Okay. Let me see if I can turn up my microphone if you bear with me just for a quick second.
Okay, okay. This is
Sorry
now
about that.
a little bit clearly audible now.
I'm just going to unshare my screen for a quick second and see if I can fix that. Oops. Are you able to see my slides now?
Yes.
Yes.
So moving on, the other piece that's important is an objective evaluation by a heart team. Shared decision-making protects you and protects your patient, right? What you want to make sure that you have is a careful evaluation by someone other than just you. Discuss the case with a colleague. Discuss the case with your surgeons. Discuss the case with a non-interventional cardiologist who can give you their perspective, or arguably a more conservative perspective on whether or not the case that you're offering to do really needs to be done. Remember, is the patient truly inoperable? Is that why they're on your table? Because if they are operable using a different technique, maybe that's better for them. Is hybrid revascularization possible? And most importantly, can you achieve complete revascularization? That's residual syntax of less than 8, so that you can get these individuals the optimal result. Number 3, whenever going into your case, you remember back in middle school when they used to say when you're writing a paper or writing an essay, it's all about the pre-planning. It has never been more important than in complex PCI. It's all about recognizing the potential problems before they happen so you can avoid them, and then having multiple potential plans to execute so that you can get the best result possible. In order to do this, you need as much information as possible before the case. So do your pre-planning, make sure you have good echoes, make sure you have anesthesia if you think you're going to need to be intubated, and make sure every medicine that can be on that patient's chart that should be there is there long before your procedure, so that when you go into a case in a controlled circumstance instead of in an uncontrolled circumstance. CHIP PCI is difficult. Emergency CHIP PCI is very bad, okay? Performance of CHIP PCI, so the actual doing the case, is a lot about the technical stuff that we concentrate on in these meetings. And I submit to you that this is only 1/5, 20% of the whole game. And that's about plan A, plan B, plan C. Making sure that you have all the equipment in the room that you think you're going to need so that your staff aren't running everywhere and they can concentrate on supporting you. Making sure that you have a complications kit inside the room so that if you get into trouble, nobody is running around trying to find the pericardiocentesis tray. It's there and it's in the room and it's ready to go for you. Whether or not you need mechanical support, what order you're going to do multi-vessel PCI, and all these things are the important things, where your access is going to be and whether the vessels are big enough. And then most importantly, when you're done your procedure, how do you get them the right aftercare that they need, right? So step number 5 is make sure that you have a net to catch you. Make sure that your CCU knows, or your step down unit knows that you're coming. Make sure that the individuals in that unit are familiar with the type of vascular access you're using, the size of your catheters, the hemodynamics that they're going to end up encountering. Are they going to, you're going to send them a patient that has an EF of 20%, but who is vasoplegic with a right atrial pressure of 0? The wrong thing to do is give that person their Lasix that day. The right thing to do is to follow the hemodynamics and give them 5 liters of fluid that day. Those are the important pieces that your CICU or your CVICU staff need to be familiar with to be able to really provide the right care. Those 5 steps, that framework, is what you should check off every single case over and over again to make sure that you have the best outcomes. So let's go through a case that I did not too long ago. And we'll talk about the specifics of each of these and then what I did to satisfy those things. So this was a 69-year-old guy with CCS class 3 to 4 angina, very, very low threshold, hypertension, dyslipidemia, type 2 diabetes. We just heard about the importance of kidney disease. Well, this guy had stage 5 CKD with a baseline creatinine of 3.1 when I assessed him. His past cardiac history indicated a long history of coronary disease. He had PCI to the left main in 2011 with in-stent restenosis. He had CABG in 2014. And then other than the Lima to the LAD, the vein graft to a diagonal, vein graft to a ramus, vein graft to a PDA were all down. So he was living on his Lima to his LAD. He also had a history of GI bleeding, which when those of you think about DAPT toleration and these kinds of things are going to recognize as a really important issue. So he presented with a history of telling me that my world is getting smaller and smaller. I feel like I live in a box and the box is shrinking because his activity tolerance was so poor, despite multiple medical therapies. And so this is the type of individual who really needs revascularization to relieve their symptoms. Forgive me for the still images here. So this is his diagnostic. This is his right coronary. It's a horribly calcified, proximally occluded, miserable RCA. He's got a lima to an LAD. He's got a distal LAD lesion that's isolating the apex with a little bit of collateralization into the distal right. He's got a tight left main stenosis in stent again, with some distal collateralization of the right from the circumflex. He's got this very funny looking anatomy that's really hard to sort out. This is actually a diagonal branch up here. And this thing here, this little nubbin, is the ramus branch that is occluded that goes all the way out to the apex. This is a better representation of that ramus. And this is where the vein graft that was on there used to attach. But now you just have a tented, distorted set of anatomy. So number one, does this patient need this intervention? Do they trust you? Well, this was the preoperative visit which is where I established that trust. It was a very important conversation to have, to be honest about the risks and benefits and to say, I can try to help you, but the reality is we're doing this to make you feel better, not to make you live longer. And if that changes your decision making, then so be it. So did we identify a suitable patient? Well, what you do is recognize the individuals with severe obstructive CAD that are approachable with PCI, who have large ischemic burdens, and in whom a good result is feasible, right? Who are probably going to benefit from your procedure. These are the people where these things intersect, those are the people that are going to benefit from a high-risk PCI. And that's how you identify a suitable patient, somebody who's really going to benefit from what you have to offer them. And remember to highlight risks of CIN, because in those types of susceptible patients, contrast-induced kidney injury is like having a heart attack on the same admission. It is the same level of morbidity. And that is a particularly bad one that you want to avoid in the patients who are susceptible for it. So what we did, we had preoperative consult with nephrology. We specifically discussed the risk of dialysis, and we had multiple peri-op visits in clinic where we would discuss the risks and benefits. And then the most important piece that was highlighted earlier by my dear friend and colleague was the careful informed consent discussion that was clearly documented with his wife in the room. So the family understands, and so did he. What about the multidisciplinary evaluation? Well, the next thing that I did was I said, can this be done a different way that might not expose this individual to as much risk? What is the best revascularization strategy and what are my goals? I'm trying to get him angina relief. I'm trying to maybe improve a little, but really I just want him to get functional capacity. And so I want to address the areas that have ischemic myocardium. That's it, right? And I want to make sure that I understand the degree of frailty that he has and whether or not he can tolerate DAPT and his comorbidities can be managed. Remember, that multidisciplinary evaluation included nephrology. It also included hematology in my case, because this individual, or sorry, GI in my case, because this individual has a long history of GI bleeding. And so we talked very carefully about not only using short DAPT stents where we could discontinue dual antiplatelet therapy early, but that he would need to be surveilled for bleeding very carefully in the early perioperative period. So we discussed with CT surgery whether or not he was a candidate for repeat bypass, and clearly with those coronaries, they said absolutely not. We discussed the primary medication adherence with his cardiologist, discussed the DAPT tolerance with GI, and made sure that we had nephrology on board with dialysis consent ready in case he needed it. So isn't this all 4 consulting services? Isn't this a bit excessive? The reality is, as a fellow, understand this today. Shared decision-making protects you. It protects you and your patient. And so the more people that you have who touch a file, who say, yes, what you're doing is right, the more solace you have going to bed at night if things don't work out the way you hope, because you know that you did right by your patient. So what about doing the PCI? So is there anything or any way that we can collect information about this case and about the patient that's going to help us identify what things we could later run into in trouble, or how we can use to maybe avoid contrast in this guy's case. So what we did was we recognized the need to avoid contrast, and we recognized the stable nature of his disease, which bought us time. So we did a zero contrast CTA. And what we did was identify the calcium in the vein grafts and the calcium in his coronaries, and use those to identify the angles we needed to actually do his PCI without using contrast diagnosis. So this is what that looked like. This was the vein graft going down to his ramus. That's what we were going to use as our primary target. This was his left main, identified by the calcium. So we knew that in this angle, we would be able to engage this graft. We identified the calcium in the LAD beyond the Lima graft, and so we knew that we would need some atherectomy here. And we knew exactly how to engage this with a wire, so we didn't have to use any contrast. All of this, we knew this is where the occlusion was. Once we got past the early part, we'd have a bunch of calcium down here, so we might have to do some hydraulic dissection with some high pressure saline to be able to get down into this area, and that we should expect calcium at the anastomosis. This reconstructed into a CT that we could then carefully look at to identify where we come down. And then we performed our procedure. So when it comes to performance of CHIP PCI, I'm not going to belabor this. This is available widely in a number of different texts out there, a number of different. But ultimately, Estrada and his colleagues in 2014 laid out very nicely key concerns with each of the typical things that generate complex PCI lesions and the tools that we need. So, for example, for chronic total occlusions, you need specialty wires, large bore catheters, microcatheters, etc. For thrombotic lesions, you need aspiration or rheolytic thrombectomy. For bifurcation, you need intravascular imaging, modern DES, and good wires. So for us, this was our treatment plan. Remember, the access is key. So we chose a bifemoral access for this patient because we knew we would have to use a vein graft. We chose a 7 French in the saphenous vein graft because we felt that was enough to give us support. And we went from the groin there, knowing that we would need a long sheath and lots of support to pass the calcium. Plan A was recanalize the occluded saphenous vein graft. Plan B was, because his symptoms were so bad and we had the informed consent discussion ahead of time, we were willing to use epicardials from a diagonal, that big diagonal that you saw in the diagnostic pictures, that could then recanalize, or that canalize the distal part of the ramus. And then our bailout was, we were going to come antegrade, which we could probably get into from the left main. We were going to do star, dissect up forward, balloon it up, and come back, so that we prevented this man from having a complication or a poor outcome. Okay. And then we were going to use the real-time imaging guided PCI that was discussed. So very briefly going through this, the distal, this was our only initial shot. This was that diagonal that we would use for retrograde. We had a shot up here. This is the calcium in the vein graft that we could see. This is the exact angle that we had on the CT. So first, we used a pointy wire and a pointy microcatheter to get through the calcium in the proximal part of the ramus. Then, once we were passed through, we used a hydrophilic wire to pass the distal calcium and knuckle through into the ramus. Remember, safety first, with a guide extension catheter inside another guide extension catheter. So this was a 6 French guide liner inside an 8 French guide liner inside a guide catheter that went telescoped all the way down the saphenous vein graft to give us the support we need. Then, once we got down to the ramus, we used the hydrophilic wire to pass that calcium and find the distal part of the ramus that we needed to identify true lumen. Remember, you never ever advance a microcatheter in CTOs when you don't know where your wire is. So here, with a selective injection, we were able to identify that we were in fact in the ramus, and we were very near an anastomosis. See this tented upwards. So at that point, we were able to pull our wire back, engage the retrograde limb, and then enter directly into the circumflex with almost no contrast at all. So far, we've only used about 12 cc's in the whole case. And this is now a retrograde CTO PCI through very nasty anatomy, all just using the same planning and approach that we did. And just to finish up, we did a bunch of ballooning and some fairly straightforward stenting. This was direct access IVUS guided stenting. So we put an IVUS into this branch. We put the stent into the branch that we needed to stent. We pulled the stent back until we saw it on the IVUS, which was what allowed us to use minimal contrast. This is the end of the stent that you can see on the IVUS. We then deployed it without using contrast. And this was our final result. This is that big, massive 3.5 millimeter ramus branch that we recreated for this gentleman to relieve his lateral wall ischemia. And this was the final IVUS to show you how big that stent really was. This was a huge branch. The total contrast for the case was 24 cc's. And after the recovery, all of the things that we talked about, making sure that they understood what to do, we found a man who had no issues with GI bleeding, who reported near complete resolution of his chest pain at 3-month follow-up, whose creatinine actually got better because his LV pressures dropped. And at 1 year post follow-up had CCS class 2 symptoms off 2 out of 3 of his anti-angios. So in summary, you can get high success rates and low complications in complex PCI. The key, however, is develop a simple 5-step approach to make sure that you do what's right by your patient every time. You're ready for trouble when it comes up. And most importantly, you can avoid complications before they happen and you can get good results. Thanks very much for your time and attention.
Thank you, Sanjog Kalra, for your brilliant presentation regarding case planning for complex PCI.
Thank you, Kalra. Before going to next presentation, I want to ask a question to Kalra. Can you hear me, Kalra? Please unmute, Kalra.
Sure,
Okay.
yeah.
We know that you are a very good chief operator. My question is, how many cases or how many percentage of your cases you used the left ventricular assistance device, like Impala? How many percentage of cases you have to use left ventricular assistance device in cheap cases?
The truth is, as you concentrate your practice onto an area of complex and high risk work, the proportion of patients where you use MCS goes up because those are the cases that you're doing. But for the typical operator who's addressing complex lesions and EFs of less than 35%, most of the time you don't need MCS. You just need really good, careful hemodynamic assessment before your case, optimizing your patient before you bring them on the table. So don't do interventions in people with wedges of 28 unless you have to, right? And then in those individuals who have truly low EFs, 20, 25%, 15%, 20%, those small group of patients need it. In my day-to-day practice, it's less than 10%.
Okay,
and that's as an operator who does mostly these cases.
Okay, thank you, Kalra. Thank you for your brilliant presentation. Stay with us. Hope we will learn from you in next session.